All right. Love that jingle. Welcome, welcome, welcome. Great to be here once again. Thank you so much for tuning in. Today's going to be a fun one. Today's a presentation that is close to my heart because it's close to my province. It's next door. It's in Ontario. The probably second greatest or third greatest province in our wonderful country after Manitoba, obviously my home province. No, serious. We're thrilled because we're talking about a year in the universal screening experience, and we have nurse practitioners today to talk to us about that. It's going to be a fun one. Stay tuned. Before we do that, I'm Rob Tatro, president, founder of the Canadian CMV Foundation and CMV Canada. Brings me great joy to be here today. I am wearing my shirt today that says, I support Bill 214, hashtag start screening. Really thrilled about that because we do have a bill live in Manitoba to have universal screening to follow in the wonderful footsteps of our neighboring province next door. So Bill 214, first reading already passed. We do need your support. If you're a parent out there, if you're a healthcare practitioner, if you're a nurse practitioner, anyone you want to get involved, by all means, please reach out to us. Go to cmvcanada.com. We'd love to get you involved. All right, this is CMV Live. It's the series that was started as a result of Ottawa 2020 being canceled. I do want to thank our sponsors. We have Merck, we have National CMV Foundation, we have NCHAM, we have CMV Canada, and obviously the CMV Public Health and Policy Conference, which is going to happen in Ottawa 2021 in August. Hopefully, crossing my fingers, if life can get back to normal. I don't know. We will update you on that right here. As of now, it is still happening. Ottawa, what a fantastic city. You got to make time to be there. It's just a wonderful city. It's our capital, and there's so many beautiful things happening. There's the parliament. It's just a wonderful place to be in, especially in the summer months. You got to come. So if you're a parent, a Canadian parent, and you're watching right now, we do have funding. If you're a U.S. parent, I know they have funding and grants available through NCHAM. So by all means, make it an effort to be there. So let's bring in our speakers today. I'm going to start by bringing in Alanna. Give me one sec here. My mouse is. All right. Alanna Webster right here. Oh, there we go. All right. Great to have you, Alanna.
Thank you.
So Alanna, you're at McMaster's Children's Hospital. You've been focusing on, you're the regional program lead for the Congenital CMV screening program in the Hamilton and London area. So welcome to the show.
Thank you.
I'm going to bring in Lisa next. Lisa Hicks. So Lisa, you are at the CHEO, Children's Hospital of Eastern Ontario. You work with wonderful PEDS ID people there. Shout out Jason Brophy, Jesta, and you guys are awesome. And you are the regional program lead for the Ottawa and Kingston area. Thank you for being here.
Yes.
And let's bring in Andrea. Andrea Baptista. So Andrea, you are the nurse practitioner in infectious diseases at the Hospital for Sick Children with Dr. Ari Bittman in Toronto. So thank you for coming, and thank you all. Welcome. This is pretty exciting. I don't want to kind of steal the thunder here, but this is really, really fun in that we're talking about 1 year in the universal screening program. For those of you who don't know, Ontario became the first place on earth in the country to have a full universal screening program. And we're going to talk about the experience from the nurse practitioners. So this is not my story. So I'm going to jump out. I'm going to let you guys handle this. And at the end, we're going to come back for questions. So if you do have questions, if you're watching on Facebook, YouTube, Instagram, wherever you're watching, make sure, first of all, subscribe. Subscribe to our channel, share our page, share with all your friends, and let us know your comments. We will get the questions to our hosts, to our guests today at the end of the presentation. Thanks so much, ladies. I'm going to step out now and give you the proverbial microphone.
All right. Thank you, Rob, so much for the introduction. We are so excited to be here today. We hope everybody is doing well today and that you're staying safe during this difficult time. We're privileged and to be part of this launch of this new program. Welcome to all our viewers. We hope you enjoy our presentation. The presentation will reflect on our first year of the Universal Congenital CMV program from a nurse practitioner's point of view. The NPs part of this program are Andrea Baptista, who covers the Toronto area, myself, who covers the Ottawa and Kingston area, along with the North, and then Alanna Webster, who covers the Hamilton and London areas, as Rob has told everybody. Hannah and Will are two NPs who were part of the program and have now moved on to a different role. So we want to thank you very much for your contributions so far to this program. Disclosures, we have no conflicts of interest to disclose. The goal of this session is to share our experience of implementing and facilitating a universal congenital CMV screening program from the regional NP's perspective. A review of the screening program and logistics of the regional NP model will be discussed, in addition to the uniqueness of the nurse practitioner role and scope of practice in this context. Furthermore, an overall reflection of the first year of the screening program will be shared. We will identify challenges, successes, and opportunities to improve. I will be outlining the NP role and scope of practice in Ontario. Please note that the NP roles varies depending on geographical location, so we just want to highlight that we speak of this in accordance to the Ontario nurse practitioner practice. Nurses are required to comply with relevant laws, standards, and guidelines as applicable. In 2008, the NP title became protected and includes 3 specialty certificates: primary healthcare, adult, and pediatric streams. Nurse practitioners are registered nurses who hold an extended class of license through additional post-secondary education and experience and can work in a variety of healthcare settings. We are regulated healthcare professionals whose practice is governed by the College of Nurses of Ontario. NPs can independently diagnose, order, and interpret diagnostic tests, prescribe pharmaceuticals, and also perform procedures. We use a holistic approach, emphasizing health promotion and the prevention of an illness, injury, and any complications for clients, with an emphasis on the need to increase access to primary healthcare and a shift from a treatment-focused approach to a health promotion, disease prevention, and community-based care. NPs can improve access to primary care and staff satisfaction while reducing the pressure on the healthcare system. Now over to you, Andrea.
Thanks, Lisa, for that introduction and the description of the NP role in Ontario. I'll be discussing how the NP role has been adopted into this program and outlining the model that we use. But first, I think it's important to do a general overview of the screening program in Ontario for those of you who aren't familiar, as well as discussing some of the key findings from the first year of the program. And I'll just keep it kind of high level, as there's already been some wonderful presentations earlier in the series by our colleagues at Newborn Screening and Infant Hearing Program, including Dr. Pranish Chakraborty, Dr. Jessica Dunn, as well as Marie Pigeon from Infant Hearing Program. So I encourage those of you who haven't yet seen those presentations to go back and view them for further details. So firstly, especially for our non-Canadian viewers, I just want to outline the 2 programs involved. Newborn Screening Ontario, or NSO, is the provincial program based at CHEO in Ottawa that screens for various diseases in infants that may not be clinically apparent. The Infant Hearing Program, or the IHP, is a comprehensive program delivered through 12 regional agencies across the province. And the IHP provides many valuable services, including universal newborn hearing screening, audiology assessment, hearing aid selection, follow-up audiology, and many services and supports for the families and for communication and language development for children. So on July 29th, 2019, NSO and the Ontario IHP became the first in the world to screen dry blood spots for hearing loss risk factors, including congenital CMV and other genetic risk factors. And it's important to mention, as was mentioned in other presentations, this is not a universal congenital CMV screening program, but an enhancement to the universal infant hearing screen. The program was many years in the making and involved a collaboration between NSO, IHP, audiology, the Ministry of Children, Community and Social Services, many community pediatricians who were rostered to the program, pediatric ophthalmology, and pediatric infectious disease clinics. I'd also like to note that the hearing screening and hearing loss risk factor screening process in Ontario is consented. So in the beginning of the program, parents were offered this additional risk factor testing. But during the pandemic, it's sort of, there were a bunch of service interruptions, particular to hearing screening. So since that period, consent has been waived. Sorry, Lisa, the slide before. There we go. So if we look back over the first year of the program, from July 2019 to July 2020, 133,235 babies were screened for risk factors for hearing loss. This was a 93% consent rate. Of these, 182 babies screened positive for congenital CMV in Ontario. The screen positive rate was less than anticipated at 0.14%. We had anticipated closer to 0.6. But of this group that screened positive, 120 of them, or 82%, with a positive urine PCR result were asymptomatic, and 22 of them, or 15%, were symptomatic. And this is consistent with what is reported in the literature. The discrepancy in the total number of 182 and the numbers I described is there's a small percentage of families who either declined the workup or results are unavailable or pending. So of the symptomatic infants, approximately half of them had sensorineural hearing loss identified, and just less than half had normal hearing. Majority of these babies, 21 of the 22 infants, were offered treatment with valganciclovir. So you can see overall this program has identified several infants with or at risk of permanent hearing loss, and this enabled their early access to diagnosis, intervention, treatment as needed, and surveillance. So now for the purposes of this presentation, we'd really like to focus on the NP model that was used in this program and identify its unique benefits, especially for other regions that are planning to start their own universal screening program. We just thought this is helpful. So this program adopted a regional nurse practitioner model to organize and facilitate the care for all babies who screen positive for CMV. So the province was divided into 5 geographical regions, with 1 NP assigned to each area to manage all of the positive CMV cases. And each of the NPs works in an infectious disease clinic at our respective pediatric hospitals. And again, as I appreciate that not all of the viewers here are Canadian, I've included a little map here of Ontario just to outline the regions, and I'll describe the number of cases or the percentages that are sort of distributed. So the Toronto region, which is major city, it's densely populated. About 50% of the cases were identified here. In the Hamilton and London region was the next biggest in terms of cases. It was about 35% total for that area. Ottawa and Kingston, about 10% of the cases, and then the big area at the top, the North Sudbury area, only about 6%, as this is lots of many remote communities and smaller population sizes. So with our extended scope of practice, NPs can provide effective care coordination through collaboration with families, various healthcare providers, and to deliver advanced healthcare services. In terms of the program development as well, NPs in each region were instrumental in designing and implementing the program, including setting up networks between the various services and establishing referral practices specific to each setting. As we highlight throughout the remainder of the presentation, the NP plays a very central role in the program for the experience of patients and families. So for the congenital CMV screen positive infants identified through the program, this is their general care pathway. So we get, so the baby screens positive for CMV on their birth drive blood spot through newborn screening. The regional NP then receives the positive result. Then before contacting the family to disclose the result, there are a few things the NP does. The NP reviews the clinical information available on the baby through various electronic medical records. And this is to assess, the baby's location and health status as much as we can determine, such as if they're at home or admitted to the NICU. The NP will also contact the baby's primary care provider to inform them of the screen positive result and obtain any further information or status on the baby. Then the NP will contact the family to disclose the result. We'll provide education, counseling, and also provide the family with our contact information for any future questions or concerns. Then there's a few referrals that we make, including to the Infant Hearing Program Lead Agency for their diagnostic audiology assessment. And in some regions, the NP will refer to ophthalmology as well. In other regions, it's the pediatrician who will refer. If there's nothing from this initial, assessment and speaking with the parents, if there's nothing to suggest thus far that the baby is symptomatic, so if they, are a well baby at home and no, past medical history so far, the NP would refer the baby to a community pediatrician who's rostered to the program for their initial assessment. If the workup is normal and baby is found to be asymptomatic, which, as we mentioned, is the majority of babies, they will continue to be followed by the pediatrician for their developmental surveillance. Alternatively, if there are any abnormalities noted on the initial assessment suggesting they're symptomatic, including isolated hearing loss, or if there were any concerns identified by the NP prior to the retrieval, the baby is then referred to their local ID clinic for further evaluation and treatment decision making. And like we said, as the NPs all work in the infectious disease clinics and therefore see these babies who are referred to the clinic, we work with our physician colleagues to determine if treatment is indicated. And if so, with our extended scope of practice, the NP can prescribe the valganciclovir as well as the monitoring blood work and arrange for further ID follow-up. So for all babies, whether or not they are symptomatic or asymptomatic and receive treatment, all results are from the workup, are sent to the NP from all the services involved. These results are reviewed by the NP, and this is sort of a last touch point to assess whether or not an ID referral is indicated if it's not already done so. It also helps to prevent unnecessary ID referrals because we can liaise with the community pediatricians and our infectious disease team. All babies, regardless again of symptomatic or asymptomatic, continue to have close follow-up of their development and hearing. So this slide is sort of repetitive, but we just wanted to highlight the process, specifically the central role that the NP plays and how it enhances continuity of care for these infants and families. Like I said, the NP is typically the main contact for these families. We sort of act as like a hub for all services and facilitating the process for families. The NP provides ongoing counseling and education to the families as needed along the care pathway. And understandably, many parents are anxious regarding this diagnosis, and the NP can spend time answering their questions. So now I'd like to pass it over to Alanna to highlight this process with some case examples.
Perfect. Thanks so much, Andrea. So as Andrea just mentioned, we will review a few cases just to highlight some of the unique experiences that we have had to date and to show how the NP model and interprofessional collaboration has effectively contributed to both patient care and also program efficacy within the first year of the program. So in this first case, the NP is notified by NSO of a new congenital CMV screen positive baby in the region. So prior to contacting the family or the baby's healthcare provider, the NP reviewed patient chart notes and found that the baby had actually not been discharged from hospital after birth and was currently admitted to the neonatal intensive care unit for many complex issues, none of which really seemed to be CMV related, and therefore the baby had not been evaluated for CMV to date. So the NP contacted the neonatal team directly and informed them of the dry blood spot result, reviewed the diagnostic workup requirements, and helped to support the team expedite these investigations. So the team was agreeable to inform the family of the CMV screen positive result and would share the NP's contact information with the family just in case they had additional questions after discharge. They had also requested that the pediatric infectious disease team be consulted, which the NP was actually able to expedite because she works on that same team. So this process of contacting the NICU team first really helped to expedite diagnostic evaluation and infectious disease referral for the baby. But most importantly, it also helped to ease the experience for the family. In this case, they were informed about the screen positive result by the neonatal team. So these are healthcare providers who they already had an established relationship with and who was already providing care to their child. Moving on to the second case example. So again, the NP is informed by NSO of a new congenital CMV screen positive baby. And at this time, she contacted the family directly to inform them of the dry blood spot result and the prognosis and plan. The family had requested that the baby be referred to their own pediatrician. So this was somebody who was already providing pediatric care to their other child and was close to their home. So the NP contacted the pediatrician to confirm that she would accept the referral, as she was not a part of the list, as I believe Andrea had mentioned earlier, of our the community pediatricians that have been registered for the CMV program. The pediatrician was agreeable to accept the referral and to coordinate for all of the necessary investigations. And once these were completed, the pediatrician forwarded the results to the NP. So the blood work results were normal. The confirmatory test, so the urine CMV PCR test, was positive. Head ultrasound, audiology, and ophthalmology results were all normal. But the pediatrician contacted the NP directly to inquire if an infectious disease referral was necessary, because the baby was actually found to be quite small on physical exam. So all of their measurements were found to be less than the 3rd percentile. So upon review and collaboration with the pediatrician, the NP, the infectious diseases team, it was decided that the baby should be referred to ID and underwent additional investigations. And incidentally, the baby was confirmed to be symptomatic and was started on antiviral therapy by the infectious diseases team. So this process of collaboration between the pediatrician, the NP, and infectious diseases team really helped to expedite investigations for the baby and also for a timely referral so that they were able to receive antiviral therapy within the recommended timeframe. Then moving on to the final case example. So again, an NP is notified of a new CMV screen positive infant and contacted the family directly to inform them of the dry blood spot, prognosis, and plan. The family contacted the NP though several days later as they still had a few CMV related questions and also informed her that the audiology testing had not yet been arranged. So the NP was able to answer these clinical questions over the phone and also connect the family with audiology directly for this outstanding appointment. The baby then was found to be symptomatic of CMV after the investigations were completed and ended up being referred to the ID team, which that same NP is a part of. So the NP was able to be present for that initial consult in the ID clinic and for subsequent follow-up visits. And she remained as the main contact for the family, and in addition to for all of the other healthcare providers that were involved in the care for the baby. So it's been very quite helpful actually to have a main contact person for the family and all involved healthcare providers to help navigate and support care for those infants that have been found to have congenital CMV in hopes to ease this experience for the families, but also to help coordinate for care. Reflecting on the first year of the program, we're all very proud of what everyone has been able to accomplish together thus far. And as Andrea had previously mentioned, so NSO screened 133,235 babies in the first year. And of those, 182 were found to be positive and 22 of which were found to be symptomatic of CMV. Now, these babies were referred then to infectious diseases team, supported by the NP, community pediatrics, audiology, and ophthalmology. And as the program has become more established, many of these babies have actually been identified very early in life and within the recommended treatment window. So in addition, we would also really like to mention, just to highlight the collaboration amongst the many, many teams across the province, those that have been in different hospitals, different cities, and different specialties, who have really worked together to be able to provide care for many of these infants. And finally, in terms of some challenges that we faced in the first year, certainly expediting tests and assessments in areas of the province that are more remote and sometimes with fewer resources has been difficult to coordinate. Again, though, having created relationships amongst the team and multiple teams across the province, it has certainly helped to make this easier to coordinate over time. We've also had some challenges with infants who have been lost to follow-up and those whose families maybe have declined any investigations at all. And in these cases, we've always contacted the primary care provider directly to make sure that they're aware of the congenital CMV screen positive result and whether any investigations were completed or perhaps those that are still outstanding. And lastly, and I think a really important challenge that the NP team has faced in the first year was really trying to reduce family anxiety related to this finding of congenital CMV. Informing a family whose baby is otherwise perfectly healthy at home about this result, and especially when we don't have an established relationship with the parents yet, has sometimes been quite difficult. Certainly we want to inform them of the result and the necessity to attend important clinic visits for investigations, but also not to increase their anxiety, as the majority of these screen-positive infants do remain asymptomatic and will continue to grow and develop, and certainly, as we hope, without concern. However, as the program has become more established, we have certainly become more experienced and knowledgeable to be able to hopefully deliver this information in both an informative way, but also hopefully too without increasing parent anxiety. So yeah, thank you so much to all of you for attending our presentation today. And certainly we do want to acknowledge the many, many people who have contributed to the program and supported us in our roles, and are so grateful to everybody for their collaboration, guidance, and support, and really look forward to continuing to work with this program.
Do one of these here because it's fantastic. Good stuff, guys. I'm so proud of the work that you guys have done. I'm so proud of the work that Ontario has done here. This cannot be understated. The sheer volume, the speed at which you move to get this done, and the sheer volume of kids that we are catching and screening is cannot be understated. So congrats. I'm proud to have you guys as Canadians. I will show a couple questions here. Amanda, good friend Amanda Dever from the US, she's asking about if it's an opt-in or opt-out. So we talked about earlier about the consent, but feel free to touch on that if someone wants to.
I can touch on that. Great question. So it's offered to all of the families, and they can consent to either having it done or not. So it's not, it's standard of care. It's not obligated for every family. Upon retrieval, if we call you and you decide at that point it's not the best thing for your family, then you are allowed to opt out.
Let's show you another one here. Amanda, another question. I was going to ask you this question. How do they decide if it's symptomatic or asymptomatic? What are the symptoms that we want to see? How many do we have to see? Clearly, hearing loss falls automatically in symptomatic. Do we need to see 2? Microcephaly obviously counts as symptomatic. What else do we need here for symptomatic?
Yeah, I can take this question. So I didn't go into details, but I'll highlight them here in terms of the workup. We just sort of said pediatrician workup, but yeah, there's a standard protocol that was established when this program was made for the workup that every infant who screens positive gets. It includes, so her question I can see, are infants getting a head ultrasound? So every baby gets a head ultrasound. There's some blood work that's done, so they check blood counts, liver function. They do confirmatory urine, which is an important part of this as well. We didn't really go into too much detail, but we have the screening test, and then we want to confirm it with a urine PCR. So every baby gets that. They also, of course, get like physical exams. So we're checking for things like their growth parameters, head circumference, gestational, their weight and their growth. And then we also have the referral to ophthalmology. So every baby should get an eye exam as well. And then their audiology. Am I missing anything there, guys? I don't think so. Yeah, so that's, so every baby gets all of those tests done. And then it's determined based on that. So if let's say they had a single finding, so isolated, liver enzymes were elevated. In those cases, that's where we were, highlighting that having, in our role, we find that that's, we can offer this service to the pediatricians where we sort of liaise with them and with our ID physicians that we work with. If there's any questions on whether or not this really warrants a referral to an infectious disease clinic, like whether or not it means the baby is truly symptomatic. And in some cases where it's like a gray zone, we'll just see them in infectious diseases, even just to see the baby, provide the family with some more education or reassurance, whatever is needed. Yeah.
So there's a protocol in place. I do want to address the third part of the question here, the sensitivity of the dried blood spot. I don't know if you ladies saw this, but JAMA, there was a JAMA article published, I think yesterday or 2 days ago, whereby Sheila Dollard, I think, was the author on it. She did I think it was a Minnesota study, showed the sensitivity of the dried blood spots in their cohort or in their kind of assay to be, I think it was right around 70%, 60 to 70%. I don't think we're seeing those numbers there, I would imagine right now, right? Because we saw 0.14% of the 133,000 births. So what do you guys think is happening there? And I know you're not researchers, but I'm kind of curious what your thoughts are on that.
I can at least try. Certainly, we wouldn't be the experts in this perspective in terms of being able to speak to all of the depths that the lab has gone to at NSO to be able to sort of cover for this. As you had mentioned, no, we have not seen as many positives as we had anticipated, but certainly are continuing to sort of evaluate this with expanded testing as best as we're able across the province. So both, as Andrea had mentioned, to always confirm these findings with a urine cCMV PCR. And also, too, to be exploring with saliva testing as well in the future. But certainly in terms of being able to catch, anytime there's any sort of clinical suspicion that there may be CMV involved, we're always then ordering serologies as necessary for testing and confirmation that way. But at least we're sort of proud at this point of being able to sort of start the trend, to be able to start to try our best at supporting those that at least that we are able to find, and certainly having a low threshold that certainly if anybody presented with signs or symptoms that might lead us to think that perhaps it was missed on the dried blood spot, to always then be able to confirm it afterwards with serology testing. I don't know if Lisa or Andrea has anything further to add to that. I'm not sure if I...
No, that's great.
No, that's good.
I think there is $1 million question here, and it's actually $1 million question. I know because I co-applied with Dr. Jason Brophy for $1 million grant with CIHR. We need $1 million, by the way. If someone wants to cut us a check for $1 million, any of our sponsors, any large cap organizations out there that have money, we need $1 million to study this exact question. We need to study what's happening with the what's happening with the sensitivity with respect to our exact, what's happening in Ontario, and are we getting all the babies? Are we not? Do we need to change the method we're doing in? So if someone out there, because for the first time ever, we have a pretty much universal assay or sample size of babies that are being screened, 93%. It's pretty much universal. It's close to universal. So it'd be great, in a perfect world, we could then take, the researchers, the bright minds that we have in Ontario or wherever in Canada, and apply them to the data and see what's happening here. Because should it really be 0.7, should we get 0.6, 0.5, something like that percentage of the population? So if someone's got $1 million to write, by all means, cut us a check, and not us. I mean, researchers, that we could help you out with that if you got $1 million. I want to touch on, and I recognize we're running low on time, I want to touch on a point you made with respect to anxiety. And I think this is incredibly important. And I think this is one of my jobs to do this as a parent. I recognize and I thank you for the work that you did. And I'm totally, I'm super appreciative of how difficult that must have been for you guys to deal with this. And I'm thankful that you did do it. And I also want to make sure that we understand here totally that what we're doing here is necessary. That level of anxiety in the parents, there's study after study that has been done that shows that as a parent, would I rather know that my son or my daughter has a 20% likelihood of developing future hearing loss? Every single parent that we ask, and we've done studies on this, and the cCMV Foundation in the US has done studies on this. Parents want to know. Parents want to know, and parents have a right to know. And I'm of the very, very strong opinion that you're doing a wonderful job. And I think it needs to be done. You need to be telling those parents what they have, because here's the thing. We know that 20% of these kids, 20% of the asymptomatics are going to develop, late onset hearing loss. We know 20%. Well, wouldn't we want to monitor those kids and follow up and say, be watching if my son or my daughter is maybe not hearing, and then follow up, take them to the specialist? Absolutely, unequivocally, because then you have an opportunity to improve the outcome, and not only that, save costs for the healthcare system. So 2 parts to that comment. 1, thank you for doing that. Thank you for going through that anxiety and dealing with the parents. And 2, in my opinion, you have to do it. So I'm glad you guys are doing it, and you're doing it well. Big, in French, we'd say chapeau, congrats. You guys are doing fantastic there. So if you haven't gathered it, I'm incredibly excited about this. I'm incredibly enthusiastic about the wonderful people in Ontario that are doing all this work. Think of it. We've had 21 babies that were treated, and that's just a start, right? We're obviously, we're going to improve the testing, improve the screening, improve it, and year in, year out, we're going to get much, much, much better numbers. And I'm incredibly thankful to be a Canadian, and this is happening. And by the way, it's coming. It's coming to the other provinces. Mark my word. It's going to start with Bill 214 in Manitoba. That's coming. #start screening. We're going to get that passed this year, hopefully. Cross my fingers. And then we're going to go to the other provinces. So I do want to give any one of you the opportunity to say a last word before I do wrap this up.
I would just like to thank you for having us. This is fabulous, and we are so excited to be here. So thank you, Rob.
And you know what's going to happen to all 3 of you? I'm going to rope you guys in to start helping us on the CMV side. We're going to start getting you involved. We're going to start getting you involved on the lobbying side, the advocacy. We're going to get you wearing T-shirts. You got it. We're going to get you going. So this was really, really neat. Again, I want to thank our sponsors, Merck and CHAM, CMV Foundation, and the National CMV Foundation and the Canadian CMV Foundation. Do not miss Ottawa 2021. You got to be there. You got to be there. It's going to be fantastic. And if for whatever reason it doesn't happen, stay tuned here for anything that happens virtually. We will be updating you. Take 1 second to subscribe to our YouTube channel. Take 2 seconds and subscribe, like, and share our Facebook page. Share with your friends. And once again, thank you so much for tuning in today. We're back in 2 weeks with Kayla's. We're back in 2 weeks. We have a presentation. It's on hearing identification and intervention among children treated for CMV. So it's really, really excited. It's going to be good. Just like this one was fantastic. Thanks so much, guys. That's it for today. See you all in 2 weeks.